Welcome back from our break. We will now move to our next panel. Our next panel is Pride, Equity, and Community, Mpox Vaccination in 2024. And I'm going to invite our panelists that are in the room to come to the stage. Vaccination is an important tool in preventing the spread of Mpox. In this panel session, the speakers will discuss vaccination efforts this year, as well as lessons learned from the 2022 response, including best practices for reaching impacted communities and Black and Hispanic or Latino men, ways to improve vaccine equity, and communication and uptake strategies. We will hear from Dr. Jennifer McQuiston, who's currently the incident manager for the 2024 CLADE Mpox response at the Centers for Disease Control and Prevention. Dr. Tevin Warren, who's a health communication specialist in the Office of Infectious Disease and HIV/AIDS Policy at the U.S. Department of Health and Human Services. Dr. David Holland, who's an associate professor at Emory University in the School of Medicine and also serves as the chief clinical officer for the Fulton County Board of Health in Atlanta. Emily Halden Brown is an Ending the HIV Epidemic Program Manager with the Montgomery County Public Health Services, who's worked on Mpox prevention. And Jasper Bowles, who's the director of the District of Columbia Mayor's Office of Lesbian, Gay, Bisexual, Transgender, and Question Affairs. And additionally, Dr. Argham Rao from the Centers for Disease Control and Prevention will be available to participate in our discussion. So I'd like to start with Dr. McQuiston. Your slides are up and you have the floor.
Thank you so much. I actually do not see the slides from my end.
They are up here in the room. Let's see.
Okay, can others who are joining by Zoom see the slides?
Yes.
Yes, Jenny.
Okay, let me just take one other possible option here. Okay, my apologies. I will go ahead and get started, but I'm probably going to need to see which slide I am on. So my name is Jennifer McQuiston. I'm currently serving as the incident manager for CDC's Mpox response, and I'm really pleased to be invited to speak with you today. Let's go to slide number 2. I think the important thing that I want to start off by saying and reminding folks of is that while we had a big outbreak in 2022 and cases have dropped dramatically since that time, Clade 2B Mpox continues to be an ongoing point of concern. We continue to have cases reported every week. Right now, we're averaging about 59 cases per week across the United States that are reported. This graphic shows the peak that happened in 2022, but also really jumps in to look at the last 6 months. October through April of 2024, you can see that those case counts have remained fairly steady over that time, meaning that Mpox is a low-level but persistent problem. And as we head into summer, we are certainly aware that when you have low levels of Mpox circulating, it could spark new outbreaks. And so getting the message out about how people can protect themselves is especially important this year. Next slide, please. So CDC has had a very vigorous response to Mpox. We're joined by lots of our partners in the interagency. This graphic, I believe that you're looking at, shows an Mpox response by the numbers. This particular graphic really shows that we've had over 1 million vaccine doses administered. There's been a very active response from the general public and the community wanting information on Mpox, with over 76 million page views of CDC Mpox websites. One of the big things we did was stand up commercial testing for Mpox, that we worked in the interagency space to expand the CDC test that was in the laboratory response network to commercial labs. And now we've been testing nearly 150,000 specimens across the country in the last several years. CDC had over 1,400 staff that worked on the Mpox response, and we continue to have program level staff that work on it. And importantly, we've been working with over 75 partners and community organizations to try to mobilize the response. Next slide, please. A couple of key milestones I want to highlight. In the first case in the United States was recognized in mid-May of 2022, and that outbreak escalated quickly. So between June and August is really when most of the US cases were reported. As the outbreak escalated, we began to distribute JYNNEOS vaccine, which was available through the Strategic National Stockpile, initially with a limited supply. So it was a really complicated a prospect of how do you distribute it, limited supplies of vaccine, knowing more are coming, trying to figure out who's at highest risk and how to get it to them. And we began to actively engage in communications to the LGBTQ plus community, knowing that they were important partners in getting the word out about vaccine and also encouraging uptake. I mentioned expansion of testing to commercial labs. That happened by really July 1st of 2022. And the Mpox outbreak was actually declared a public health emergency of international concern by the WHO and a public health emergency by the US government, which meant that a White House task force was created in July. And at the same time, we were actively working with partners and state and local health departments and advocacy groups to help ensure that as much JYNNEOS, which was now coming into the system, could be distributed. So over 1 million doses were started to be distributed to the state and local health partners for administration. Cases began to decline rapidly by August of 2022. And survey and modeling data now show that it wasn't so much the vaccine timing that contributed to that decline as protective behavioral changes in persons at high risk for exposure to Mpox were being embraced, and that those protective behavioral changes contributed really to the collapse of that outbreak. And then September of 2022, as it became apparent that vaccine was not really always being equitably accessed, we started to launch some strong health equity initiatives to improve vaccine access and uptake, particularly among Black and Hispanic persons. And we also came out with new data that really showed vaccine performance was quite strong with a high degree of efficacy shown. Next slide, please. Additional key milestones have happened even since the outbreak really started to become more of a simmer during 2023. So ACIP voted to recommend that the 2-dose JYNNEOS vaccine series for people 18 years and older who are at risk for Mpox during an outbreak, that was voted on and approved in February of 2023. In April of 2023, we highlighted risks for fatal outcomes and impacts on Black and Hispanic persons as a way to continue to highlight some health inequities. Cases have been in a low steady state, really reached their lowest point April through September of 2023. There was a slight uptick in October, but that has now remained steady, as I mentioned, at about 59 cases per week. We had a publication in the MMWR in late May of 2024, which really highlighted that most cases in the US continue to occur in people who are unvaccinated or undervaccinated, only receiving 1 dose. And so we're trying to capitalize on that information to really encourage people to go out and get vaccinated. Next slide, please. So some important lessons from the Mpox response have been highlighted in a publication that the deputy lead for the White House Task Force authored in 2023. I'm going to talk about some of these here. I think one of the most important lessons was the need to take an approach that deeply engages the community most affected. So that means engaging, listening, and acting on suggestions from the GB-MSM community, particularly when we had the White House Task Force activated. They were really strongly engaged with advocates and worked to really make sure there was strong coordination between all the partners, whether it was federal agencies, state, local health departments, and private entities, and to make sure that the information we were giving out was timely, tailored, and uniform and seamless. Another lesson learned was to keep the public health response really flexible and responsive. So I mentioned the rapid expansion of commercial testing. I also touched on this. We had to have a rapidly evolving vaccine strategy that was based on initially limited supplies, then increasing, then shifting to the possibility of an intradermal dose. But we also modified our recommendations based on feedback we got from the communities being impacted by mpox, including where we recommended the location of an injection site be. When we learned that they didn't really like having it on the forearm, some people didn't like having it on the forearms because it might leave a darkened area for several months. We began to approve the location of injection sites that might be able to be covered by sleeves, for example. And then also the removal of risk assessments to determine eligibility for vaccination. We heard loud and clear that there was a perception this could be stigmatizing, and so just putting out the recommendation and then letting people self-identify as being at risk, I think really helped move some of that acceptance. We had another lesson learned in the importance of really having flexible resources and investments. So mpox at CDC was always based out of our Division of High Consequence Pathogens and Pathology, which is really where smallpox is based because they're genetically closely related. But because the clade 2B outbreak really spread through sexual networks, particularly among gay, bisexual, and other men who have sex with men, and recognizing that there are other important diseases being spread similarly and impacting them similarly, emphasizing a syndemic approach with those other activities and really using some of their resources and investments to add on monkeypox, mpox, I think was really important. And finally, a big lesson learned was continuing to invest in the foundational research. So the reason we had Jynneos vaccine pre-approved for use at the time the mpox outbreak started was because we had decades of research into vaccines that could be used to prevent smallpox should that reemerge. It's important that we look at mpox as a pandemic potential pathogen in its own right, and I think more research is needed to understand, medical countermeasures that work best for mpox and how we can improve our understanding, uptake, and the science around vaccine delivery. Next slide, please. I started with this, and I'm going to end a bit with this. Clade 2 mpox is not over. It continues to circulate among cisgender men, especially those identifying as gay or bisexual. Most cases continue to be in people who are unvaccinated, meaning they've never presented for a vaccine, or maybe people who got one dose of vaccine and haven't achieved maximum levels of immune protection and could really benefit from getting that second dose, no matter how much time has passed since their first dose. We know that people with severe immunocompromise continue to have a much higher risk for severe and fatal outcomes. We continue to have deaths due to mpox, people who were infected months ago, but because of their immune systems being so compromised, they've not been able to mount an immune response, and some of them do succumb to those infections, which is always tragic. There's a lot of local and regional spread that's happening. Most of our cases are not reporting international travel, so that suggests that these are homegrown in the United States. And we have an emerging trend of some TPOXX resistant cases. We've had over 50 that have been detected, including 18 new cases in at least 5 states in the last couple months. So monitoring this, because TPOXX has been one of our primary investigational drugs that we've used to treat severe infections, and we don't want to really see resistant strains circulating in the United States, so monitoring that. We continue to really recommend 2 doses of Jynneos, no matter how long it's been since the first dose. The new commercial availability of Jynneos that's been since April 1st adds some complexity to this. The supplies that are being sent out through the Strategic National Stockpile are available right now, but projected to be phased out by August, in which case accessibility shifts to commercially available resources. And there is some concern that this could increase access issues, equitability, and so some conversations around that I think are important to have. And then we get this question a lot. No booster is recommended at this time. We don't see epidemiologic signals of waning immunity, but we're continuing to monitor this and assess it. So did want people to know that we were monitoring that. Next slide. This just shows vaccine administration, and you can see that we have had much lower uptake really since the outbreak kind of ended. So 2023 and 2024 have had very low uptake levels. Next slide, please. ways that we're trying to encourage vaccination, our CDC Foundation, which is one of our partners, has a new campaign with Deshaun Wesley, who is an influencer that really came out in the last couple weeks that emphasizes the importance of 2 doses and talks about why that's important to protect not only you, but your chosen family. We've got new science out in the MMWR I mentioned, highlighting the importance of 2 doses. We also have some modeling data indicating that outbreaks of more than 100 cases are unlikely to occur if population level immunity is over 50%. And that can be achieved either through a combination of prior infection in a region or county, plus vaccination on top of it. So this new data is important for counties to say, you know what, we don't want large outbreaks in the future. We want to aim for a 50% population level immunity. We've got calls actively happening with our state, local, territorial partners, highlighting that and also emphasizing that they can use the crisis COAG to fund unique ways to improve vaccine uptake. And you're going to hear more from our OASH partner about Summer of Pride. So next slide, please. I'm going to end on this slide. Clade 2B, of course, is still of significant concern to us, but in the background, we have a different situation emerging. There is an outbreak of Clade 1 mpox, which is a more severe form of mpox with a higher mortality rate. That's happening in the Democratic Republic of Congo right now. Over 20,000 Clade 1 mpox cases have been reported in that country in Africa since 2023. And the concerning thing is something similar happened in Nigeria for Clade 2B for several years before it spilled out and became a global outbreak. So we're watching what's happening in DRC and actively working to try to prepare here for the possibility of this and help them control it, because we have a window to stop this now before it becomes the next global outbreak. So stay tuned on that. Right now, there's no evidence that Clade 1 is circulating in the US. We're actively looking for it, but I do want to flag this for awareness for everyone. And that, next slide, that is it for me. Thank you so much.
Thank you very much. Our next presenter is Dr. Tevin Warren from OIDP. Tevin, your slides are up. You have the floor.
Thank you. I can hear myself. Again, thank you so much for having me. My name is Dr. Tevin Warren. I am a health communication specialist within the Office of Infectious Disease and HIV/AIDS Policy, and I am thrilled to speak to you all this morning about our HHS-led Mpox Equity Intervention or initiative that we call Summer of Pride. A lot of what I was prepared to speak about, Jennifer actually covered, so thank you, Jennifer. And I'm also not an epi guy, so she did a fabulous job. But I am going to briefly repeat some of the things that she said. So in the US, Mpox activity remains pretty low. We are seeing some localized surges in metropolitan areas like LA, New York, Chicago, and as of recent, Charlotte. However, as Jennifer mentioned, there is a bigger outbreak that's happening in Western and Sub-Saharan Africa, particularly the Democratic Republic of Congo, that has us a bit concerned back in the States as the summer months commence and we start to see more international travel. On your screen, I hope that you can see the 3 graphs here, but they are basically depicting that Black and Brown LGBTQI+ communities and populations, they are overestimated in Mpox cases and related deaths, however, underrepresented in vaccination rates. And that's due to a myriad of systemic and structural barriers like language issues, travel issues, low confidence in vaccines, as well as just a lack of awareness of the vaccine. And as you all know, and as Jennifer mentioned, ACIP recommends that persons 18 years of age and older receive the 2-dose Jynneos vaccine as it is our most effective tool against Mpox. Let's see here. So this might not be a surprise to several of you, but Mpox is interconnected with several other health challenges. In fact, the majority of Mpox cases is attributed to late-stage HIV, STIs, as well as unstable housing. And severe outcomes such as hospitalizations and deaths, they are often compounded with stigma, mental health struggles, and substance use. So recognizing all of this, a lot of federal agencies, including CDC, HRSA, SAMHSA, and HUD, they actually extended their funding flexibilities back during the 2022 Mpox outbreak, which allows for their grantees to be able to cover Mpox-related activities. again, recognizing that Mpox is a syndemic issue that requires a more whole society coordinated and syndemic solution. And with these funding flexibilities, it really allows for the federal government to be able to advise local jurisdictions on how to implement syndemic wellness programming that doesn't just incorporate Mpox vaccines, but also access to HIV and STI resources and other related services and resources. As Jennifer mentioned, CDC really does a great job with monitoring Mpox. They did a wonderful analysis back in 2023, which they've recently updated, where they looked at ending the HIV epidemic, or EHE, jurisdictions that had low and medium Mpox immunity, meaning that their vaccination coverage for both doses of the Jynneos vaccine was below 30 to 35%, which is a really good indicator for identifying those jurisdictions that have a higher potential for a recurrent Mpox outbreak. So really having an understanding or a landscape of those priority jurisdictions where we can focus in our efforts, as well as just having an awareness of the breadth of systemic and structural barriers that contribute to vaccination disparities. Back during the 2022 Mpox outbreak, the federal government, with HHS and the White House at the helm, we really wanted to engage in a solutions-focused conversation with community to really see how they felt that we should address this Mpox equity issue. And among several great suggestions, they gave us some really strong directives that we can hone in on. They primarily told us that we should be getting vaccines to pride festivals, specifically Black and Hispanic-centric prides, house and ballroom community events, pageant community events, and even sex on premises venues, activities, and spaces like bathhouses and circuit parties. So hearing community, we developed an intergovernmental team that partnered with national umbrella organizations for Pride festivals and for house and ballroom community. And we worked together to identify up to 30 events that were occurring within those priority jurisdictions from the previous slide throughout the months, the summer months, and throughout the fall as well. And we would connect the event organizer with the local health department, as well as the local federally funded grantees across the syndemic, with the charge of working together to develop a syndemic wellness plan that incorporates, again, not just Mpox vaccine and referrals and information, but access to other routine vaccines like COVID, flu, RSV, meningococcal, hepatitis, HIV and STI prevention resources and linkage to care, harm reduction, mental health services, and also access to the NIH STUMP trial, which is the clinical trial for the TPOXX, which Jennifer was mentioning. And I have been doing several presentations, briefing a variety of audiences on the Summer Pride Initiative. And one of the big questions that I get is, what is the tie-in with house and ballroom and pride festivals? And back in 2022, there was a lot of data from vaccine confidence reports, as well as just personal or individual insights from local health department staff that said that one of the most successful strategies that they were seeing regarding driving vaccine uptake was actually implementing vaccination efforts in non-clinical settings in which LGBTQI+ populations frequent. So your pride festivals, house and ballroom community events, et cetera. Another thing that is so great about these spaces is that they also offer a unique opportunity to reach individuals who may have access issues due to stigma or a lack of health coverage. And these spaces are also national and regional magnets for Black and Brown LGBTQI+ populations. So with Summer of Pride, we're able to leverage those spaces that the communities with the highest need, we were able to essentially meet them where they are. And on your screen is 2 examples of really successful community vaccination events held at both Atlanta Black Gay Pride and then another popular LGBTQI Pride Festival in Louisiana. And finally, this is our Summer of Pride events list. As you can see, we start before the summer, so in late spring, and we go all the way until pretty much November. A lot of the Black and Hispanic-centric prides and events. They often occur outside of the traditional Pride Month, which we're in right now, and in the summer as well. So that is reflected on your screen. If you have any questions or want to know more information about the Summer of Pride initiative, or you want to know about more of the planned activities that we have for specific events, please feel free to reach out to me. We are always looking to amplify what's happening across the country with Summer of Pride, as well as open to opportunities for collaboration. And with that, I want to say happy Pride and thank you so much for your time.
Thank you very much for your presentation. Our next presenter is Dr. David Holland from Emory University.
All right. Good morning. I'm actually not with Emory University anymore. I'm actually with the Chief Medical Officer at Mercy Care in Atlanta. I've been there since September. However, when I did this work, I was at the Fulton County Board of Health, where I was the Chief Clinical Officer. This is kind of to orient you a little bit about what Fulton County is, where it is. It's about 90% of the city of Atlanta, the rest of which is in DeKalb County. It's got a population of about 1 million, of which about half of that is Atlanta. And this is just the way that Georgia organizes its health departments. It's not by city. And you can see the demographics there. There's not a majority within Fulton County. And just a little orientation, I'm going to talk a little bit about EHE. These are the other 3 EHE counties that are all in that Atlanta metro area. Now, we've seen this a bunch, but this is what the data looked like. This is what it looked like for us here in Fulton County, or there in Fulton County. And the important thing here is this, looking at the racial disparities. About 80% overall of our cases were in non-white individuals. Now, I just want to say, and I know Jennifer's on the line, that I'm trying not to be too critical of the federal response in this particular setting. However, I do have to point out that there are some of the ways this affected us at the local level in order for our intervention to make any sense. And I just, want to say, like, this, we had just come off of COVID. We knew how to do mass vaccination events. We had vaccines sitting on the shelves, ready to go. So it could have been pretty easy. Also, gay men love vaccines. There's really good data from COVID that in all racial and ethnic groups, vaccine hesitancy is way lower in gay men than the rest of the population. So, it could have just pulled it off the shelf and go. But that's not kind of what happened. So we had this PEP plus thing, which was the criteria that we used. And basically it just said, you have to have multiple sexual partners in a couple weeks, fit into certain groups. Unfortunately, this meant that people who are already stigmatized about their sexual identity, sexual behavior, everything, had to go to the health department and say, I'm this, I have this many sexual partners. Trans women, had to identify as such. So it created some barriers. Also, this is the line on there is where we got the vaccine for the first time. I will let you can see that we're already in the exponential phase of the curve. Vaccines are obviously more effective the earlier you do it. So, we're kind of already behind here. Now, the other thing that happened is that, as Jennifer mentioned, the vaccine supply in the initial portion there just wasn't a lot of the Yenios around. And there were a lot of people that need it. So we got the vaccines in little dribbles because it came to the state and then we got some. And we usually knew like by Tuesday how many we were going to have for the weekend. So, we were trying like in real time to schedule appointments and that sort of thing. And there was this huge demand that created this kind of Hunger Games. Everybody's like looking for the announcement, waiting for it to come out, trying to get an appointment. When we did our first vaccine event, which was 200, 90% of the people that got the vaccine were white. Now, at the time, we didn't really have good data about the racial distribution of our cases. So we knew that was a problem, but we didn't know how big of a problem it was. Nationwide, it was mostly white guys. So, we knew we were going to end up with racial disparities because we always do, but we didn't really know how bad. So what did we do? We knew that was a problem. So the first thing we did was we reached out to all our community-based organizations that we partner with for HIV testing. So these are people that we already have a relationship with that in turn have a relationship directly with community. Their clients trust them. Their clients may not trust us, but they trust those organizations. And we reached out to them and said, we need a list of people that you can, that would meet these criteria that we can vaccinate. For the second event, we kind of were pushed. So all we did was we had this online link to appointments and we sent it out to the CBOs ahead of time before we posted it publicly. The idea was to give them a 2-hour head start. After 25 minutes, half the appointments were gone. And we were like, well, we can release it publicly. And, it still worked. But after that, what we did was we reserved Friday. We did vaccines Wednesday, Thursday, and Friday. We reserved Friday as our CBO day. And each CBO was given a certain number of vaccine appointments for that day. Like, okay, you're a smaller one, you get 25. The larger ones got 100. And we didn't need to know their names or anything like that. I mean, we did eventually, but we didn't need them to use our system to make appointments. They just got this number of appointments. They sent us the list. People showed up. We vaccinated them, and it worked. Here is the way that it came out over periods of time through the summer. And as you can see, we were able to actually reverse the disparity, where roughly 70% of our vaccines went to individuals who were non-white. And maintained that, by the way, through the summer. At some point in there, toward like August, was when the intradermal vaccine was approved, and then there was plenty. And then it's just a logistics, like how many can we do in a day? So it was less of a problem at that point. The other thing though, is that, we took a lot of feedback from our CBOs. How is this working? Is this working for you? That sort of, we fine-tuned our, the way we release the appointments and things like that. But we also got, as Jennifer mentioned, a lot of feedback on the intradermal administration causing these hyperpigmented spots, which were cosmetically unappealing. So we created this flyer. I reached out to a dermatology colleague of mine on, what to do with that if that happens. And in advance of the CDC guidance on you can give it into other spots, the INEOS EUA allows that. Like that's, if you actually read the EUA, it had that in there. So we we started allowing that in other spots to allow that. And this was actually really, really well received. Overall, 75% of non-white recipients got their second dose. And I don't know, I'm really proud of that. And somehow or another, my number got deleted there, but in 2023, which was the following year, we had fewer than 20 cases as a result of, we also had a lot of morbidity. So some of that was obviously infection, and some of it was the vaccine. And we did give out about 7,000. So we were pretty stoked about all that. And I think, yep, that is my last slide. So I appreciate y'all's attention, and I will anticipate questions later. Thank you.
Thank you very much. Our next presenter is Emily Holden Brown from the Montgomery County Public Health Services.
Good morning, everyone. My name is Emily Brown. I use she, her pronouns, and I am the Ending the HIV Epidemic Program Manager in Montgomery County, Maryland. Some of you may live there if you're in this room. We are a 1.1 million person county just north of DC. Actually, before I get started, I want to say thank you so much to my colleagues at Maryland Department of Health and DC Department of Health who have worked alongside us with this response, and all my colleagues at HHS at Montgomery County as well. So we are a very large county, very close to here. We are sort of a suburb, but we are always among the most diverse U.S. counties in the U.S. We are considered a wealthy county and a healthy county by all of the measures that you could probably Google. And we have low unemployment, high health insurance rates, but of course, pockets of poverty, inequality, and we actually do have a growing lower income sector in Montgomery County. So my health department, Montgomery County DHHS, has been providing services to our county since the 80s. We are a relatively small shop at Silver Spring headquarters there in Dennis Avenue Health Center. And since 1988, we've been it in terms of safety net HIV STI services for the county. It's a pretty large county. Excitingly, in 2019, we were named an Ending the HIV Epidemic jurisdiction. And just a high-level overview is that this is a federal partnership. HHS with HRSA and CDC infused high incidence jurisdictions with resources to reduce new infections by 90% by 2030. So we were maybe a little bit surprised to be named an EHE jurisdiction, but extremely excited to join our neighbors in Prince George's County and DC and Baltimore in this endeavor. And that is why I work at Montgomery County DHHS. So we were charged with making a jurisdictional level plan to address disparities and high HIV incidence in Montgomery County. And we assembled a huge group of CBOs, other health department stakeholders, Maryland Department of Health, DC Department of Health, and created our jurisdictional plan. And part of that was to identify priority communities. And two of our priority communities for our Ending the HIV Epidemic jurisdictional plan were Black and Latinx, gay and bisexual men, and other men who have sex with men, and trans and gender expansive communities. And this was certainly the first time our health department had really looked at equity through an intersectional lens officially, acknowledging both race and ethnicity and sexual orientation and gender identity and its relationship to disease vulnerability. But also it made us kind of think through what is the landscape of services and community in Montgomery County specifically? What does that mean to a suburb of DC that has a thriving queer community and very diverse and intersectional, and being close to Baltimore, same. What does it mean to be wedged in there? And what can we do to ensure health and wellness? So we are so grateful for this infusion of resources because we were able to, yes, earn that lens, learn from our community partners about what our county was and was not offering to these communities, but also to expand our services to a second location to provide HIV and STI services at 2 county locations and 2 separate, one underserved part of the county, Up County, Germantown, and to gain a community outreach presence for the first time. So we were able to take the services that we weren't providing anywhere but in our one clinic to a second clinic and expand out to the community through pop-up events, mobile events, and static sites at community-based organizations, to Dr. Warren's point, non-clinical environments where people felt safer. And one of the first things we did was create the county's first ever sexual health and wellness campaign, and that was intentionally sex positive, LGBTQ inclusive, and intersectional in focus. So all of the people, some of them real people in our ads and in our PSAs represented our priority communities for Montgomery County's EHE plan, and we got social media for the first time. We used all of our funding to make sure that we had a diverse portfolio of ways of communicating with the communities that we're serving, and in multiple languages as well. So we have Do It For You MC, that's our campaign, and Hazlo Por Ti in Spanish. And importantly to this discussion, there was no regular Pride event in Montgomery County, and certainly nothing that really fit the bill in terms of intersectionality. So Montgomery County Health Department in 2021 launched Pride in the Plaza in downtown Silver Spring. And we partnered with Capitol Ballroom Council. As Dr. Warren mentioned, the ballroom community has long been a wonderful public health partner in sexual health and wellness overall. And Live in Your Truth programs. These are intentionally intersectional LGBTQ plus organizations that serve Black and Latinx communities specifically. And that festival has grown into a huge annual event. In fact, I'm planning one year 4 right now. But we are also able every year to do the Pride in the Plaza Health Services Suite. And at that suite, we have been able to provide a lot of HIV and STI testing, information, get to know communities, make appointments for PrEP, syphilis screening, et cetera, back at base. But it's really just a fun way to connect with communities and connect communities to all the information and services that we provide in the county. So how did that affect our MPOX response? It's clear probably already that we rolled MPOX into that campaign immediately. We wouldn't have had that campaign and that PSA without EHE and all the resources that brought us and the lens that brought us. I couldn't agree more with Dr. Holland's assessment that scarcity is really the enemy of equity. So what we saw immediately was a huge interest from a lot of folks who were white. And so we can't really only look at one identity, right? Gay and bisexual men, that's one part of a person's identity, but we have to look at race and ethnicity. And there's no health disparity in race or racial health disparity that we shouldn't anticipate out of the gate. So we knew this was going to happen. We created on our end a pre-registration that allowed us to screen pre-registrants for the highest priority communities and make sure that they got priority for our appointments. So if I had data to share with you today, it's actually still being processed. It would look a little bit like the opposite of what Dr. Holland showed us. As scarcity loosened up, the people being vaccinated in Montgomery County started to look a lot more like the general population in Montgomery County, but the folks that got those first appointments were really likely to be part of those communities who needed it the most. And Pride in the Plaza this year, we will have MPOX vaccination. We've been continuing to vaccinate folks in our STI and HIV clinics. There's been a pretty consistent interest, and we keep those campaigns going. We keep MPOX forefront. People ask us questions about new outbreaks all the time. We always tell folks, get your second dose, let's be prepared. And generally speaking, that sex positivity and that intersectionality, I think, has kept us both proactive about this, and also has built trust over the years, because we don't want to stigmatize anyone. We don't want to say it's you and your identity and your behaviors that are leading to an increased risk. We are very humble about the fact that our structures, the structures that we have created in HHS at every level, have led to these disparities being very predictable. And had we not been prepared, it would have felt disingenuous. So I'm so grateful for this opportunity to talk about this series of events and relationships that EHE allowed us to build. And I'm thrilled to see our partners at the federal level talking about syndemics and intersectionality, because those two concepts really are the backbone of our work, and we're hoping to continue with this work. That's it for me.
Thank you very much. And our final presenter for the panel is Jasper Bowles from the District of Columbia Mayor's Office.
All right. Good afternoon, everyone. My name is Jasper Bowles. I have the honor of serving our LGBTQIA+ community in Washington, D.C. And I'm really excited to be here today to give you the community perspective on MPOX and what we're doing to be inclusive of all healthcare outreach and initiatives with our LGBTQ community. I also want to preface, we are not a healthcare agency, so there are not going to be all the graphs and charts and data points from my fellow colleagues, but I think that this is actually a great build on that. We really utilize our partnerships with folks like DC Health and our federal partners to promote the different grants, programs, resources that we have. So I want to talk a little bit about who we serve, and then I want to talk about how our events are health-centered, how our programs are health-centered, and then I think we'll have an opportunity to talk about more during the panel. So the mission of the Mayor's Office of LGBTQ Affairs is to address important concerns to our LGBTQIA plus community. We do that by empowering our LGBTQ youth leaders. We do that by empowering our businesses and our nonprofit organizations, and by building a cohesive community across all 8 wards of Washington, D.C. And of course, we focus on providing resources for those most at risk. So we are just one of 13 other community affairs dedicated organizations within government. As you'll see on the screen here, we have the Mayor's Office of Latino Affairs, the Mayor's Office of Asian Pacific Islander Affairs, of African Affairs, of Caribbean Affairs. There's a broad, diverse community that DC it proudly supports and empowers. And we see it as vital as a government to have dedicated advocates in these communities to better navigate those resources, to be advocates for those communities, and hopefully, which we'll see and what we've heard, create better outcomes for these communities, which you'll see, are either most at risk of homelessness or most at risk of employment disparities or health disparities. So Mayor Muriel Bowser and DC are very proud to have these dedicated advocates within DC government. So a little bit about what we do. Majority of our time is just navigating DC government's resources. So whether that be from tickets to getting people connected to PEP and PrEP, delivery services, or really the whole gambit of things. We do focus on a few specific services for our community because we do know that they face higher disparities, and that is health, employment, as well as housing. So to talk a little bit about more what that looks like here today, we have our health partnership with DC Health, who is more specifically working with HOSTA, which is our local HIV, hepatitis, STI administration. They know what it's like to put equity forward, and that's why they partner with our office to do so many different things, whether that be programs, such as having a dedicated staff member, but also events, which we'll talk a little bit about next. We also provide dedicated housing vouchers for our LGBTQIA plus community members. We also are the agency that provides cultural humility and cultural competency training for all of our DC government employees. And then we have a robust grants program. We're actually one of the largest LGBTQI dedicated grants funders in the DC region, dedicated just for LGBTQ programs, with a little over $1 million. And then a lot of folks in DC and the region really know us for hosting signature events, which I think is actually the next slide. So to give a little background on what our grant component looks like, and this is one way how we push our message and our resources from our health partners, from our safety partners. We utilize this grant funding. So a majority of it is for our LGBTQ community development grants, and that is based on the priorities that we have set. Health is always one of those priorities. So, we're looking to give this additional funding to community-based organizations. The 2 other pieces are our cultural competency grants. So we provide funding to our community-based organizations to then receive training for all of the different folks within DC government. It's actually a legal requirement to take this course if you're a housing service provider, which is a great opportunity, especially since we know that many of our LGBTQI plus youth face higher rates of folks of experiencing homelessness. And then our newest grant is our violence prevention and response team, which I'm really proud to expand in this next fiscal year. But this grant is for our community-based organizations who can provide resources for those who have experienced victims of hate or hate violence against them. And so we have two components, our response. So if you are a victim or a survivor of crime, we're able to connect you with legal resources or trauma-informed counseling. But next year in FY25, we'll also be expanding our outreach component to provide opioid prevention and harm reduction outreach efforts. So we're really trying to create that holistic approach for violence prevention. So what should have been before is people know us for big events. If you're from the DC region, we just most recently had our Pride Parade and Festival. We are not the organizing community-based organization that hosts that. However, government plays a very large role in ensuring that it's a safe event, but it is an event that is focused on our community. It is very welcoming. We also host the 17th Street High Heel Race, which is now in its 38th annual year. It is we're one of the only jurisdictions in the world that supports this type of event. And we literally shut down a street for 3 blocks, and we host a sprint of about a few hundred community members. They all have to be in at least 4-inch heels to run. And it is a great opportunity to showcase our diverse LGBTQ plus community. There's a great story that comes to that. And then, of course, we had our 2nd annual LGBTQ flag raising just this June 3rd. So we are out in the community, people come to our events, and why is that important, and why is that important here today? Well, we talk about health at every event. Our largest sponsors, our largest partners, we make sure that they are at these events, and we make sure that they are not just tabling, but they have an opportunity to support in so many additional ways. So one of the reasons why we think being in community is core to the success to eliminating and addressing our increased health disparities is it provides a direct connection to services. I mean, we are actually in the community tabling, we are actually meeting folks face to face, following up with people, creating additional partnerships. We have become and are continuing to be credible messengers. Yes, we are government, but we're the fun side of things. We're the community affairs side. We work with people in community, and we hire people that are in community. And then last is collaborating with partners. We understand that we cannot do this alone. And so making sure that we have community buy-in and community support, not only when it's the good times like the Pride Parade, but when people need resources, whether that be COVID or MPOX. So I kind of broke this down into 2 sides. You know, our office hosts LGBTQ dedicated events, and we want to make sure that there's health focus in that. So for our 17th Street High Heel Race, obviously we had first aid on site in case somebody, has a sprained ankle. But more importantly, we got people tested. We got people connected to Narcan or naloxone, and we had a great opportunity to get people to destigmatize health and to really showcase that getting tested is a great opportunity because they can get connected to Beyonce tickets or they can get connected to bigger prizes and more perks. And, we really look to destigmatize it, so we constantly talk about it. Another really awesome event that we partnered with most recently was at the Howard Theater. We had a Know Your Status Kiki Ball, and I know we talked a little bit about the ballroom culture and the ballroom community. it was such a great opportunity to be in this space, to connect people with resources, but no one has said it yet, but to party with a purpose and to be in these spaces where you may not think that you could get connected with resources, but you can. And this was very significant. DC, if I was DC Health, I could tell you the numbers of all of the folks that were tested and the Narcan that was connected and getting connected to PrEP and PEP. But connecting those services and creating events where people want to be, that has been shown so extremely successful. Of course, there's also health dedicated events. So partnering with DC Health to make sure that whenever we do have an event, such as National Youth HIV Awareness Day, that we're focusing and bringing to light our LGBTQIA plus youth, that we're bringing to focus our LGBTQIA plus community. So we have found great partnership with our local health departments. To ensure that whenever we do have these awareness days or whenever we do have these larger events that may not be specifically for the LGBTQ community, that there still is that intersectionality, there still is that approach. And we've honestly, whenever DC Health has an event, our community turns out. So we're really glad to continue that partnership and strengthen it. So our office being a community-based office, we do still have two different programs. So I do want to outline our health coordinator that I briefly spoke of. With his approach and his connections and direct connection to our health department, but being located in partnership with our office, we've seen continued impactful events and partnerships. We've expanded our naloxone training and administration to become a designated site within the district. We've expanded our condom distribution. And again, we have been that one, we have really tried to turn ourselves to that one-stop shop to connect if people need health resources. And we've done that through Instagram, by connecting folks, by creating credible messengers, and really just becoming the hey, DM us if you have a question or if you need something. And we're not the resources, but we connect people to the direct resources. The other part of that is providing community-based grants directly to organizations. So we are proud to provide funding to one of the leading LGBTQI HIV organizations in the DC region and nationally. And I just took a snapshot of their Q2 reports this year. So between January and March, for a very limited amount of funding, we were able to get 55 DC residents tested. We were able to get 4 DC residents treated for Mpox and 133 folks vaccinated. And this is just a small, our funding is just a small portion, a small piece compared to the greater amount of funding. But what has been great about this is because they're a part of our community development grant program, we create partnerships with the 38 other grantees that are within that program to share resources, to make sure that they are partnering at other events and partnering with different programs and really creating this synergy. My goal with our grants is not to just give funding to people, but really create a partnership. So what more can we do? What more connection do we have to get better resources for our community? So I did want to briefly point this out. Next year, Washington, D.C. will be hosting World Pride 2025. And there's no way you could read all this, but essentially it's the largest LGBTQIA plus event internationally. We're anticipating a little over 2 million folks to be coming to the DC region between May 23rd and June 8th. And we are working with DC Health and our Department of Behavioral Health and our public safety cluster to make sure that this is one of the safest and healthiest events for our community. We went to Sydney, Australia last year, last year. And we were proud to better understand what the lessons that they learned. And we're really excited to have, our healthcare goals focus on providing healthcare services, making sure that there's testing and vaccinations and vital information in the places that people are, not just at the festival, not just at the parade. But also making sure that we are working with the folks who are already credible messengers and funding them, providing the supports that they need to be in these spaces. I did want to talk a little bit that's not on here. I thought it was just such a great opportunity in terms of great partnerships. DC, if you're not aware, to host the Mid-Atlantic Leather Festival, which many in the community and outside of the community really know it as a kink festival. And I am just so proud of the partnership that DC Health has with the community and the partner that they have grown with Nasty Pig, which is an LGBTQ dedicated business, and they create clothing wear. And what I found so incredible about this partnership is that Nasty Pig, as the clothing store, they have such a great connection with this community. And we know that people at MAL face a higher risk and that they need, PrEP, PEP, Mpox, all of these things. And last year, in 2023, ahead of MAL, DC Health, for the first time, created a partnership to make sure that Mpox was at the MAL host hotel. And it was originally people were like, is this actually going to work? Are people going to do this? Like, are people going to go and get tested here? But once we showcased and marketed it, we helped with community outreach, but DC Health, of course, was providing the services. There were lines. I mean, the results were so high and of getting vaccinated. And it was so much good credibility within the health department and the businesses and the community to come together to have better and safer outcomes for our community. So I know that wasn't a part of the presentation here, but I do want to give kudos to that specifically for Mpox, making sure that, we're touching all parts of the community, not just the folks that are attending the festival, but folks that may be taking part of riskier activity, and making sure that we're putting credible messengers in that space to give resources. So with that, I'm excited for questions. Thank you.
Thank you very much, Jacob. I want to thank all the members of this panel. You've given us a lot to think about, and sad to see that we continue to see Mpox in our communities, but we are in a better place than we were at least a couple of years ago, but we've still got a ways to go. Are there any questions or comments from members of the committee, either in the room or online? Molly, please.
Yeah, and Dr. McQuiston kind of touched on this, but with commercialization of the Jynneos vaccine and it no longer being supplied by the federal government, I'm wondering if any of you have thought through how you'll continue to administer Jynneos to individuals who don't have insurance, especially with there not being a vaccines for adult program or additional 317 vaccine that states can supply for uninsured adults.
Hi, thanks for that. So we do have Dr. Agam Rao on with CDC, who I think has more information in this space. I do want to say that it is a bit of a rock and a hard place. I think there are some people who are not accessing vaccine because they don't want to self-identify, going to specialized vaccine clinics and things like that, and the availability of vaccine through their normal doctor's office without any kind of self-identification publicly, I think might lead some more people to get vaccinated. At the same time, I think the equity issues around lack of insurance are definitely going to be magnified. So Agam, I don't know if you have anything that you want to share here.
Yeah, so we have been having very frequent calls with Bavarian Nordic and with a multi-agency group of people that includes ASPR and CMS and CDC and others. And so we've been talking through all these issues pertaining to insurance, and at least until August. I mean, I know that this is topmost on people's concerns, but we're continuing to have discussions about it. My understanding is that once some of the CDC contracts associated with I guess my expertise is not associated with these contracts, so I can't speak exactly to it, but it sounded like our immunization safety division was going to implement a lot of the same contracts that they've done for other vaccines. So my understanding, and perhaps I can connect you to the people in our group if you have more questions. My understanding is that it's similar to the processes for other vaccines. It's true, it would be great if we had a vaccines for adults program, but the access issues should be similar to those for other commercialized vaccines for adults. But I also just wanted to weigh in on what Jenny said. My concern is indeed remains just that there's not enough people who are vaccinated in general. I agree with you that the people who without insurance are a huge problem. I mean, we have a 24/7 consultation program at CDC for the severe cases because therapeutics are only available, certain therapeutics are only available through consultation with us. And these cases, we've already had 58 deaths in the United States, the most deaths of any other country in the world. And these are almost all, I would say all, severely immunocompromised patients, typically with advanced HIV, CD4 counts often in the single digits, who are not connected to medical care, did not know they had HIV, did not get vaccinated. Almost all of them have not been vaccinated. So it is a really important thing that we have to work on, because these consultations are just devastating. We get reconsulted and reconsulted. The patients are in the hospital for 6 months at a time or even longer. They have very, very severe disease. Nothing like, I mean, the typical patient, I understand that there's issues surrounding like having pigmentation and things like that. But these patients, my goodness, like it's just heartbreaking to see what they're going through. And so reaching those individuals is really important. But those patients aside, we still have a good number of patients who have received only a single dose of the vaccine or none. And we did do some analysis at CDC to try to understand those people who've been partially vaccinated. And they seem to have the same demographic characteristics as the people who are fully vaccinated. So perhaps it's an out of sight, out of mind sort of thing where they're not thinking that Mpox is an issue and that they're not realizing they need to be vaccinated. We are still seeing these cases. So even though this is really very much a success story in many ways, we do have a ways to go. As people have already said, we only have 25% of the people who are recommended to receive the vaccine being fully vaccinated in the US, where there's so much vaccine available.
So I have a question from the chair, and Tevin, this may come to you probably most directly. You know, I live in a primarily rural state in the middle of the country. You know, we've talked about stigma. We've talked about a lot of these real challenges that even in larger urban areas where there may be more a sense of community, I see a real challenge with stigma and identification, particularly in our rural and near urban communities. Do you have any thoughts about how we might reach out to people in those settings that are probably even less vaccinated than those in our urban settings?
Yeah, can you hear me? Yes. So to your point, I'm also from a rural area, and this is something that personally I'm invested in. So something that we've seen that is a very successful strategy when it comes to those more rural areas is actually partnerships with academia. There's like, I'm from Alabama, so University of Alabama is right down the street. So it doesn't matter what your nationality is, your sexual orientation, your gender identity is. People are always in Montgomery, Alabama, screaming Roll Tide. So any type of partnership with the University of Alabama, it just makes sense. So amplifying that across the country in those rural areas is what we're seeing that's very successful. We've also seen this very successfully happen in frontier America. Just partnering with academia. Also, those organizations or established businesses that are outside of the sexual orientation, the pride, like they don't, it doesn't matter what your sexual orientation is. So we're seeing partnerships with barbershops, and we're seeing successful partnerships with community centers and things of that nature. So thinking more so multidimensionally, and then also just like partnership. I think that is our way to addressing that rural disparity. So
And getting moms involved potentially also.
moms, yeah, absolutely.
Mitch Rothholz.
Thank you all for great presentations. Just playing off a little more on the commercial question. There are some health departments who are doing a nice job of collaborating with community providers, not just because there's a stigma of people going to the health department, but working with providers in the community, like some community pharmacies who I know are providing some of these services. Give a little perspective if any of you have worked with some health departments who are doing that, or maybe from NVAC perspective, we may want to bring some of that to this discussion as well. And again, going back to the insurance question, there is that stigma about being identified with insurance. So two things. One is August is a deadline. What are we doing to encourage those who still need their second dose, that if they don't want to have to put money out of their pocket or go through their insurance, that deadline is coming up, you can still get it free, pushing that deadline in there that might push some people to go ahead and get vaccinated. And second is we might want to have a discussion on our agenda coming up too, is how are insurance companies handling this vaccine with their constituents? Because I think that's an important part. We want to remove those barriers, but how do we do it understanding and taking into account the sensitivity of the individuals who we're serving?
I can speak a little to that. So in Fulton County, it wasn't just Fulton County, but kind of Atlanta Metro. As more vaccine came in, it at first just went to the health departments, then it went to the Ryan White funded agencies. So it's some FQHCs and things like that. But then as more of it became available, some private they were able to get access to it if they their primary patient population was a lot of gay men. So it was available that way. And as far as the insurance stigma goes, I don't think anybody's actually billed this to insurance yet, so we don't really know. But for a lot of those insurance stigma things, what the stigmatizing thing isn't the vaccine itself, but the diagnosis code that you use with it. And there's need for vaccine basically is a CPT code, as a diagnosis code. It can, there's you can get real specific, like need for pneumococcal vaccination, and and use that. But then for some of these, like there's not going to be one for need for the you can just, there's generic need for immunization kind of code that you could use for that just makes it very generic.
Just to follow, do you think providers know what code to use?
Doctors are going to use the easiest code that will get them paid. So whichever one, if you're using Epic, whichever one, personal experience, the fastest one I can type in that box that is going to get Aetna to reimburse me, that's the one I'm going to use. So, and it's hard to type need for pneumococcal vaccination. Pneumococcal is a long word. And you can't just say pneumo because it will go into there's 1,000 words that start that way. So, yeah.
Dr. Rao, you had your hand
Yeah,
up.
I was just going to say that it's on the routine immunization schedule now. So that is a pathway for reimbursement from insurance. So I also know that Bavarian Nordic has been working really closely with various pharmacy chains like CVS and Walgreens. And in states where pharmacists can give vaccines, it's already available in CVS. So pharmacies states where pharmacists can give vaccine, like in New York State, for example, they cannot. But in other states they can, and CVS already has it available. You can book it online, and Walgreens will very soon make it available. There's also other pharmacies that they've told us about, they seem to think that a lot of pharmacies will have it available. I can understand the stigma issue. Our hope is that because it's part of the routine immunization schedule, that's similar to other vaccines that are given in STD clinics and in HIV clinics, but also primary care clinics, that it will be given. I led the ACIP work group, and that's the Advisory Committee on Immunization Practices. I led that work group that reviewed all of the data on this, and we had on our work group many STD clinicians and HIV providers as well, who all unanimously really said that when we asked, is it going to be difficult for you to administer vaccines in your clinic, if once this is commercialized, they all said no. We routinely are giving vaccines in clinic, including in STD clinics. We are also routinely giving, therapeutics for STDs in STD clinic and HIV clinic. And so this would just be rolled in. They didn't seem to think it would be any different for them. And we're actually looking forward to commercialization. Even before commercialization, there was a trend away from health departments and more towards individual clinics providing the vaccine. And our hope also is that just now that it's on the routine immunization schedule, it's going to be something that clinicians think of when they have a patient with HIV in their office, or a patient who's presenting for STDs, and they will routinely go through all of the other vaccines on the routine immunization schedule and think about whether their patient qualifies. I mean, it is true, it's dependent on the relationship that a provider has with the patient, whether the patient tells them that they have certain risk factors, but the wording of the ACIP recommendations is such that the clinician, if they feel that it's possible that they could be at risk, can go ahead and give it to them. And so hopefully that facilitates more access.
And if I could add one last thing on the stigma, just a reminder that Jynneos is not an Mpox vaccine. It is a smallpox vaccine that we're using for Mpox. So when it's, Jynneos, inactivated smallpox, whatever. So even the vaccine itself doesn't have that connotation exactly. So.
Yeah, that's true. But the ACIP recommendations are very much focused on sexual risk factors.
Oh.
And it's not intended for all men who have sex with men. It's intended for people who have certain sexual risk factors. And that includes heterosexual women who have sex with bisexual men. But it is very much sex. Like.
Oh, I agree. I'm just talking about, like, when you're talking about like stigma associated with insurance reimbursement, when the vaccine prints out, like, even if you're looking at which vaccines you got, if you're, the vaccine itself, if it's printed out, does not say anything about Mpox. So it may be, less stigmatizing that way. All your points are entirely correct. I just, when people show up at a clinic for treatment of HIV, for example, and one of their diagnoses is human immunodeficiency virus disease, and that prints out on their after visit summary, that can be a problem. So those are the types of things where the stigma comes from. And if you kind of get rid of that, then the stigma it's not as much of a problem anymore.
So I was hoping I could jump in and address one thing that was brought up in that question. It's, the question of, should people be getting their vaccine now while it's free? I do want to say that there's sort of a sliding scale of availability and we don't have an ASPR representative here who administers the strategic national stockpile, which is how Jynneos has really been given out up until the point of commercialization. So while they are fulfilling orders from states who are requesting it for particular events and things, the number is not being pre-positioned and the number is coming down. So I don't think the message is go out and get a vaccine now while it's free. I think the message is you need to have 2 doses of vaccine if you are at high risk for Mpox, and here are your resources to do it. And I think there are increasingly available commercial routes that are easy to access. Thanks.
Any other comments or questions? Well, hearing none, I want to thank all the members of this panel. It's been very important, and we appreciate all your efforts. We may ping other people to talk to you about how you've been successful in your own areas to help spread the message and get people vaccinated and protected against mpox across our country. Thanks. So we now reached our lunch break. We are now going to take a break until 1:30 p.m. Eastern Time. I want to thank everyone who is online and in the room joining us for our June 2024 NVAC meeting. We will resume promptly at 1:30 with fall and winter respiratory diseases, the vaccination season ahead.
Produced by the U.S. Department of Health and Human Services.